This was categorically a different study and had a different look at the outcomes. But if I were to summarize everything, many years of research, the induction rates with anti-TNF therapies ranging from weeks 2 to 6 are very similar, surprisingly similar across the studies. Roughly 60% of patients will have a response to an anti-TNF antibody, regardless of which agent you're looking at. And if you look at the initial responders and their long-term maintenance of response, so you could multiply these outcomes by the initial response rate to get the final overall response rate, then what you see at somewhere at month 6, which is where these studies are all comparable, again you see about 50% to maybe as high as 60% of the initial responders still responding out at 1 year. And remission rates are roughly half that amount. So this has been a common expectation for all the anti-TNFs, and one thing that I should point out is, of course, this leaves many patients who don't respond to our ultimate therapy and still suggests there is a need for additional therapies with other mechanisms. And I really won't talk about that at this point right now, because I really believe that we get very far with anti-TNF antibodies, but the real question is how best to use them. Now, as I said, I'm not going to talk very much about ulcerative colitis, but all of our basic scientists suggested that TNF was not a very important cytokine in ulcerative colitis. Systemically, you find much lower levels. You do find relatively high levels of TNF in ulcerative colitis in the mucosa, but it was hotly debated about whether this would be an effective therapy in ulcerative colitis as it is in Crohn's. And I don't think there's any argument left after these studies, Act 1 and Act 2, that the response rates and the remission rates are pretty much what you expect to see in Crohn's disease, albeit these are different outcome measures for a different disease. What is really quite different about the anti-TNFs in Crohn's disease, as well as in ulcerative colitis, is the capacity to heal the mucosa really very quickly. And these were images that appeared on the cover of Gastroenterology that really kind of shocked the IBD community, seeing these long serpiginous ulcers in the pretreatment phase to healing here. And sorry, the light doesn't make this show up very well, but this is really complete healing of the mucosa in a 4-week period. And we are not used to seeing this with other therapies. We don't expect to see this with, particularly with steroids, where perhaps you may see 1/3 of patients who may have mucosal healing, but in fact that healing doesn't correlate at all with the clinical outcomes or symptoms of the patient. In addition, we have very robust evidence that even in complicated disease, you can see marked therapeutic benefit. This is the Accent 2 study. It's really the largest randomized controlled trial looking at patients with fistulizing Crohn's disease. So fistulas, of course, are a dire complication of Crohn's disease, most often will lead to surgery if you can't induce healing medically. And here you can see that 69% of patients responded to induction treatment with Infliximab at weeks 0, 2, and 6, the standard treatment, 5 milligrams per kilogram. And then maintenance dosing would maintain fistula healing and clinical response over a 1-year period in 36% of patients compared to 19% who got placebo maintenance. So you can see that there is a benefit here. It is statistically significant. I think it's also a clinically meaningful difference given how refractory these patients are. But still, there's a lot of room for improvement. And we've also been able to demonstrate in these longer-term maintenance studies that there is also an effect on decreasing the numbers of surgeries and procedures. You can see that there's a more than 50% in decrease over placebo maintenance in the Infliximab maintenance arm. As well, we see with anti-TNFs, and these are data from the CHARM study with Adalimumab, you also see a decrease in the hospitalization rates with maintenance dosing with Adalimumab. There's a relative risk reduction of 78% at 3 months, and at 12 months, a 57% risk reduction. We've known for a long time that the major cost of care is represented by the cost of surgery and the cost of hospitalization. So these are important outcomes not just for patients, but also for the economy of care. And very recently, actually in this month's Gastroenterology, we had evidence that in postoperative prevention of recurrence of Crohn's disease, there's at least endoscopically apparent benefit. When you put patients on Infliximab after their ileal resection, you see a much lower rate of endoscopic recurrence in patients who are maintained on Infliximab compared to placebo. So after a complication has occurred, after a surgery has occurred, you can have prevention of recurrence of disease, apparently, at least endoscopically. We need a larger study and longer-term follow-up to know if this is really clinically meaningful, because the endoscopic appearance is clearly just a surrogate for the long-term outcomes, we think. So the real question is, how can we best employ this very useful set of agents in treating the disease? And what we've come to understand that Crohn's disease and possibly also ulcerative colitis are diseases that are cumulative in their structural damage. And what you see is the majority of patients at diagnosis have inflammatory disease without a penetrating or stricturing complication. They don't have fistulas, they don't have strictures. These are the things that will typically lead to a surgery. But over time, you see an increasing number of patients who go from the inflammatory phenotype to arise one of these complications. And when you go out to 20 years, most of the patients have had at least one complication of their disease. Also from the same group in France, we have this interesting study where they looked historically at the use of immunosuppressives, azathioprine, 6-MP, the things that we really had around in the 2 decades between 1978 and 2002. And you can see that by 2002, there were more than half of their patients who were using immunosuppressives. And despite this, the rate of surgery in these patients changed not a bit over these 2 decades. So these we think of as very potent agents. Why are they not reducing the rate of surgery if they're truly effective agents? Well, the question is, are we using them at the optimal time in the course of the disease? And the question then has become in this field, can early intervention improve the natural history of Crohn's disease? And if you think about this model, we start in a state of complete health, then probably there is a long or short period of subclinical inflammation where we don't know the patient has the diagnosis, but the disease is sort of grumbling beneath the surface. Eventually they become symptomatic. Over time, most really, will develop one or more complications of their disease. This will lead typically to a surgery or to disability over time. So if you think of where we intervene, we can prevent relapse or recurrence after a surgery. That's like the Ruggiero study that I showed you before, where Infliximab was given after a resection. We could prevent complications, in other words, treat a patient before they've had a fistula or a stricture. If we really could identify patients very early, or we knew that they were genetically or environmentally susceptible to the disease, we could prevent it. We're nowhere near that stage. Or we could prevent the occurrence of symptomatic disease. But for the most part, our treatments really focus up on this end of the arrow. Now, perhaps the earliest example of an early intervention study in Crohn's disease is this study by Markowitz, where they took children who had never before been exposed to corticosteroids or to immune modulators. They were sick enough to require a course of steroids. All of them were treated with a course of steroids, a steroid taper over 12 weeks. And at 12 weeks, you see that nearly 90% of patients have a remission. But what happens over the following 18 months? Well, you can see that only 9% of the kids who were put on 6-MP had a relapse, compared to 47% of the patients assigned to placebo. So this also correlated with a much lower cumulative dosing of corticosteroids, which is very important in children in their growth, and is a suggestion that you can improve the outcomes if you intervene very early in the course of disease.